and management of the early GI cancers. And NBI, as we know, that it is one of the advanced image endoscopic technique. And for our today's discussion and guidance, we have very esteemed faculty amongst us. Dr. Naresh Bhatt sir is with us. As such, he doesn't require any introduction. But Dr. Naresh Bhatt is the chief gastroenterologist and hepatologist at the Esther CMI Hospital, Bengaluru. Sir is the chairman of the Indian NBI group and a core member of the Asian NBI group. And he trains the endoscopist in India and across the Asia in advanced endoscopic imaging. Sir has been in practice for more than 30 years as a pioneering gastroenterologist in the country. And he was the president of Society of GI Endoscopy India and presently the president-elect of the AIG, governing council member of Indian Society of Gastroenterology and the president of ISG Karnataka. So, without wasting much time, I would like to invite Dr. Naresh Bhatt sir to deliver his talk on the role of NBI in the diagnosis of early cancer. Dr. Naresh Bhatt sir, please.
Thank you and good evening. I'm actually not going to speak too much on NBI. I think we can talk about NBI tomorrow. But I'm just going to speak to you all about how we can improve what we are doing today. How many of you here are endoscopists? All of you? Everyone? Okay, so great. All of you are gastroenterologists, so there's no mixed crowd. Then what am I? Okay, I should have changed the thing, but fine, it's all right. A lot of you are young, including my good friend Nilay. So our endoscopy was more at the top right there. That was our endoscopy in our days. And then we were lucky to have these lecture scopes. And of course, you all have been brought up on the video endoscope, so everyone can see what is going on. So your learning process is obviously much faster than what we did. I remember my first ERCP sphincterotomy that I did. I had never seen a sphincterotomy ever before that, because when Dr. Dilavri did his ERCPs, he alone could see. We could never see what he did. So I had to just read some 4 pages of a book from Venu and Geenan and read it 10 times that night to find out how do you do a sphincterotomy and where is your wire. And of course, I had a zipper, fortunately with no bleed, but it was primitive then. Okay, so just coming back to endoscopy, if you look at esophagus and the both squamous cell as well as adenocarcinoma, you find that the median survival is pretty dismal. And CA esophagus is one of the worst cancers to get because the 5-year survival is so low. If you look at cancer stomach, we find that most of the patients that we pick up are advanced cancers, and again the 5-year survival is low and average survival is about 2 years. So whether it's esophageal squamous, esophageal adeno, or whether it's cancer stomach, we are not doing great quality of work. Colorectal cancer is somewhat better, because even if you pick them up at stage 2, 3, we're getting reasonable 5-year survivals. So colorectal is less aggressive in that sense, or maybe we're doing a far better job. But all this just tells us that we are diagnosing it at a stage where it's not making big difference to the patient. We are giving them a lease of life of a couple of years, but nothing more. And finally, if you look at stage 1 squamous cell carcinoma, if you look at patients who have even submucosal involvement, if you do a endotherapy and then follow it up with a chemo-RT, you find that we're not only talking of 5 years, we're talking about 10-year survivals. So the simple message is pick them up early. Stage 1 cancer is what is going to make a difference. So at this stage, I'm just going to stop and ask how many of you here use any kind of advanced modality for endoscopy. I think here there's nothing to be it's not a test of your skills or things like that. Just a simple thing is, maybe I'll start off with you. How long do you take to do an endoscopy? How long do you take? 5 minutes, okay. What about you? 2 minutes. Yeah, see, this is a fact and we have to accept it, and I'm very happy that you've been honest, because this is what all of us were doing and this is how we were taught. Jaldi karo, next patient wait kar raha hai, you don't have a recovery room, you don't have anything. You're not sedating the patient, because if you sedate him, he has to lie down somewhere. If you don't sedate him, you can get the next guy who ek Vati Savlon mein you dip your scope, that's your disinfection. I mean, that's a different story together, but the simple fact is that we are not spending enough time. And obviously, with these Maggie endoscopy or 2-minute endoscopies, we're going to miss a lot. So where do we need to improve? We need to improve in terms of early recognition. We need to get more accuracy in our diagnosis. And finally, of course, we are all here to change outcomes. Because it may be, it's your own relative that you're doing an endoscopy. And believe me, when you do your own relative, you're not going to change your practice, because that's what you've done for the previous 15,000 other patients before that. So you're going to do the same. But if we want to change outcomes, we need to change how we start doing things. So the first thing is, what is your intelligence and skills? Intelligence, I'm sure all of us who have reached this stage have our intelligence there. We all have skills. All of us know how to do endoscopy. But I'm just going back one step, is before we start an endoscopy, maybe I'll ask you, Pratim, what do you do? I mean, suppose there's a patient that Chirag has seen the previous day and says an endoscopy, and it's your endoscopy day. What do you do? Okay. You read his history. Let me have a show of hands. How many of you write a history more than 6 words? Okay. Very few. Okay, all of you not putting hands? Great. How many have made 6 sentences? Couple? All right. Detailed history? Very few. So I'm happy that there are some of you doing it, but I'm sure it pay you big dividends if you write good histories. And as he rightly said, is before we start doing an endoscopy, you need to start off with, what is this patient that I'm looking for? I'm looking for a DU, but that's not good enough. Is he a smoker? Does he drink? Does he have a family history? What are his risk factors? So we need to put in all that information, and it doesn't take too much time. Once you've reached that level, all it takes maybe 30 seconds. But you need to go through that process. So all of these are important aspects before you start doing endoscopy. The next set is the skills to pick up the suspicious lesion. All this is stomach. All these are cancer. All right? So how do you pick up the suspicious lesions? All of us, when we are taught in medical school, what are we taught? Does this chap have, can it be cancer? No. Why? He doesn't have a lump in his abdomen, he doesn't have supraclavicular node, and he has not lost 15 kgs. That's what we are taught, and that's what we continue to teach. So we need to sort of mentally erase what we've been taught in medical school and realize that every patient who is having a procedure there may be having a cancer. And that you have to make a good attempt to find out if he's got cancer, where is it, and pick it up. So, which means that every single patient, your endoscopy has to go through a systematic approach. And that systematic approach, as I said, starts before you doing the endoscopy. And when you're doing the endoscopy, start looking for a suspicious lesion. And that suspicious lesion may be just a color change, it may be a texture change, maybe looking a little rough, maybe looking a little depressed, maybe a little raised. There may actually be an ulcer, maybe a tiny ulcer, or it may just not distend. I have a lot of patients who have an advanced CS stomach of a linitis plastica and endoscopy report is normal because there was no lump that was seen. But if you just look at the distensibility, you can't find the distensibility. So even these subtle things, so we all think that, okay, maybe those small things I'm missing. No, we are actually missing a lot. And I must tell you that at least in Bangalore, I am sure in Ahmedabad you must be far better. But in Bangalore, I find at least 40% of endoscopies that are repeated, and repeated not several months later, a few weeks after the index endoscopy, that is, I find that the findings are totally different. That means somewhere along our practice of endoscopy needs a huge change. For example, if you have a patient with dyspepsia, everyone finds it very sort of tempting to write grade A esophagitis. And why? Why would you be tempted to write grade A esophagitis? Correct. What else? Good point. Yeah, what else? And then you just write a PPI. हो गया काम. 2 मिनट में PPI लिख दिया, चलो बाहर. Right? अगर normal लिखा तो पूछेगा क्यों? Then what are you going to say? Functional dyspepsia क्या है? वो घोषाल प्रोफेसर ने कुछ बताया था, क्या क्लासिफिकेशन याद नहीं है क्या? Some psychiatric medicine they use, forget it. PPI लिख के भेज दिया. So that's it. Unfortunate temptation for all of us. And that is why now if you look at the newer classifications, grade A is almost ignored. They don't even consider it as esophagitis or evidence of GRD. But yet we continue doing this. That is why I said 40% of reports are wrong. And we are only writing it. So we need to look at the endoscopy's thing, and you'll find very subtle 2 millimeters, 3 millimeters, all those patients that Nilay and Chirag and some of you are doing ESDs are extremely small lesions. How do they get picked up? They get picked up because someone has been careful, looked at that lesion, interrogated it, and so in Ahmedabad, I must talk to you in business terms. So you spend time and picking up a lesion. Instead of making 3,000 rupees, you make, I don't know how much Nilay charges, but anywhere from 1 lakh plus. All right? So for ESD. So in pure business terms, it makes sense to pick up these lesions. Forget about all the satisfaction you're giving the patient and his family and quality of life and so on. But just if you are selfish and want to look for your own, I think it makes sense. Okay? Now it's all about color. I mean, I'm sure all of you will say this is gastritis. I mean, why even in the biggest institution in India, the professor of gastroenterology had a lesion like this and they called it gastritis, didn't biopsy, and he had full-blown see a stomach within the next 7-8 months. So this is something that we have to unlearn. So if you find something there, you need to interrogate it. Well, it may be gastrite, maybe a small erosion, but it can also be a cancer. So it's all about color. When you're doing endoscopy, those little changes in color, little red color, a little white color, little depression, all those is, you must sort of sensitize your eyes and your brain to pick it up and interrogate it. This is basically about equipment. We all know about resolution. Resolution is where the pixel size is small and the pixel density is higher. So that is a high resolution thing, and that's why you need a monitor or a system that is a high resolution monitor. It makes a difference. Magnification is different. It's just the number of enlargements and how the details can be better seen. For example, here you have an enlarged image on the top, and here you have an enlarged image with high definition. And here you can pick up the surface pattern so well. So just don't go and say, oh, I've got magnification. You put one button, you get magnification. Doesn't necessarily always give you better quality. So you should have both magnification and much better resolution. So I think you must invest in this kind of equipment. A good monitor goes a long way. So don't pick up your old TV at home and put it there and say, I'll save some money. It does make a difference when you use. Okay, coming to now, the next thing is, what are we looking for? In Robin's pathology, we learnt about angiogenesis and neoangiogenesis for cancer. Cancer needs nutrition, and where is the nutrition coming from? Blood vessels. Does this work? So if you look at this normal, this is basically the esophagus. There's nothing there. You find that this is the blood vessel here, and these are the capillaries here. These are called the IPCLs, right? Now, once you develop a tumor, now you look at these IPCLs becoming a little bigger. The blood vessels are increasing to feed that tumor, right? And once it becomes even bigger, if you look at these, which is here, on endoscopy you'll find that these vessels look no longer recognizable as these IPCLs. They have become fat because more blood needs to go in. So the fundamental fact that we need to understand is, for cancer, we are going to expect changes in the blood vessels. And of course the surface pattern. But the blood vessels is what you're going to focus a lot of attention. And that's going to tell you as to, is there a tumor? How aggressive tumor? Is it going down? Is this sort of the vertical depth of the tumor is increasing? All that is that information is going to come from looking at the blood vessels, and of course at the surface pattern of the mucosa. And so what research workers did is that they exploited this fact that light, when you split it up into the various components, know that the depth of penetration varies at the end of the Vibgyor spectrum. The R goes deeper and this end remains very superficial. So what they did, and you can look at this, if you just have very superficial, this is what the surface you can see, while if it goes very deep, you can't see much of the surface. So they exploited this, and this is what they do in NBI, is they use these superficial things of the blue and green light, and they say, okay, we just use this, so what we are interested is only the superficial layer. What's happening to the superficial mucosas? What's happening to the superficial vessels? And they try and highlight it and are able to interpret it so that that's what you're actually seeing on your screen. And this is what narrowband imaging is. So we are using a narrow part of that entire white light band and trying to look at these vessels. Now, the question that I get asked is, Is it only NBI that I need to use? No, not necessarily. There are, all systems have their own side of technology. You call it NBI, you call it blue light imaging, you call it optical enhance thing, which various companies, they're all almost equally there. The only thing is that we know that for NBI, we have much more data, more papers, more people have used NBI over these last 2 decades. Blue light imaging has just started in the last 5 years, 6 years, mainly in Japan. Not many other countries have used blue light imaging, but they're all the same. So it doesn't matter really what scope you have. You can exploit the same information if you have this technology. Okay? So don't say, oh, I don't have NBI, so I'm going to do, my quick endoscopies and I'm going to come out. No. Okay, if you look at cancer, now if you look at intramucosal cancer, look at these blood vessels. These are the IPCLs in the squamous mucosa. So look at the benefit with higher magnification and resolution. You can make this out pretty routinely. And if you look at this, that there is some amount of submucosal infiltration here. Looking at these vessels look certainly abnormal. This is at least looking something like an IPCL, but this is not even looking like an IPCL. So just by these patterns, you can make a diagnosis whether there is an abnormality and go further in finding out what is the extent of the abnormality. And this is what you have to train yourself. That's all that it is. Now same thing here. Now you see a lesion here and lesion here. Both look the same. No difference, isn't it? Do you think there's a difference between the two? They're both tiny, a little depression here. But if you use interrogation, you find that this is an area which looks, definitely these vessels are abnormal, a little more irregular, and this abnormal area, but they're more regular. So when there's regular, irregular, you'll find this theme coming up again and again. Then you can say, okay, this is abnormal, but it looks benign. This looks abnormal, this looks suspicious for cancer. Okay? So that is all that you're going to do at endoscopy, is try to find out, is there a lesion? Interrogate it. Is it benign or likely to be suspicious? And then you biopsy, resect it, do whatever you want. But your steps are do an endoscopy, recognize a suspicious lesion, interrogate it, and then proceed further. And look at the current bandoscopes. Nila, do you have one of these fancy scopes? TXI? Not yet?
You have it?
Hopefully in a month or two we should be able to get something. But look at the beauty. Look at these pictures. And believe me, once you see a lesion, it just takes 15 seconds to get this kind of information. These vessels are definitely abnormal. This Nele would resect without even waiting for a biopsy. He'll just go and resect it and send that whole specimen for histology. Says, my diagnosis of early gastric cancer. And the pathologist, even if he's not so good, will have to agree that it is. Okay? So this is the beauty about this technology. It's something that you are seeing, recognizing, and get confident. And the whole thing is all available to you at your fingertips. So you don't have to change scopes, do something else. No, it's all available there. So look at the steps, as I said. Identify with white light, endoscopy with magnification, interrogate with NBI, and look at these surface and vascular patterns. That's what you think. This is Barrett's. All of you agree? Now, do you think some area looks abnormal? We don't know. So unless you look carefully, you're not going to pick it up. Okay, now you look carefully, say, okay, I'm not sure. Barrett's, pura to dekhna padega. So when you start looking, find that here, you can find out in this area, this is definitely abnormal. So this is early cancer in Barrett's. And this is something that Chirag can easily do. He just put a band, resect it, and it's over. 10 minutes, you have got rid of that cancer, and then you treat the Barrett's subsequently. So there is a tangible financial gain when you recognize a lesion like this. This is something that we do very often. This is Barrett's. You need to interrogate. You may say, I got only 2 minutes. अब तुम बोल रहे पूरा Barrett देखो 5 मिनट के लिए. बाकी का भी देखना है. So what we do is we use various kind of red flag techniques to find out. It's very difficult to keep looking at each part of Barrett's and देखो उसका irregular है, irregular है क्या है. So what do? We use something called acetic acid chromoendoscopy. And you just spray acetic acid and you see, you can make out such a beautiful pattern. And this can easily highlight. Here, this is Barrett's, and you find that this loss of, normally when you put acetic acid, it turns white, right? You find that this area doesn't turn white, and that is very suspicious for abnormalities. Dysplasia, inflammation can look like this, but dysplasia, malignancy will have this. So it's very easy to pick up. So you interrogate, look at that lesion, and if you look at it clearly, you can make out that this is certainly not irregular. Here morphologically it is looking a little raised and normal. So similarly, you have red flag techniques even in other systems like the Pentax. Yes, I think LCI is Pentax or okay, no, not iScan. LCI is Pentax or Fuji?
LCI is Fuji.
Fuji. So they have also a red flag technique that they use LCI, and if it shows a little orange color, it tells you that that's an area which is looking a little abnormal. Now, if you look at the colon, we know about the polyps. They have classified it as type 1, 2A, 2B, 3, and you can predict based on this whether there's a hyperplastic or a serrated polyp, mild dysplasia, and here is high-grade dysplasia or carcinoma in situ, and of course a deep submucous invasive cancer. And this prediction is reasonably, once you sort of get a little experience, you can have about 90%, 95% sort of confidence, except in this here, there is a bit of an issue in 2B, becomes a little more difficult, but for type 1, type 2A, 3, is, sort of performance is very good. For example, this vessels are very different from this. So this is a hyperplastic polyp, right? This is 2A, and this is a classical adenomatous polyp with low-grade dysplasia. Now these vessels, if you look, are regular. Here these vessels are a little more irregular, maybe a little thick in areas. So this is a dicey lesion. You're not sure whether this actually has got aggressive cancer or not. So 2B, as I said, is a little unreliable, and you may need to look at it with other modalities. They use crystal violet in Japan. But here, this definitely is Janet 3 with deep submucous invasion, where it automatically goes to the surgeon. So these patterns, if you can recognize, it's not very difficult. And in our unit, we showed way back in 2008, 2009, when we started doing NBI. And after I got trained, I spent 4 sessions with my younger colleagues and then let them do endoscopy for a few weeks. And at the end of 4 weeks, when I held a quiz they were as good as me, which means that the learning curve is not very long. It's a short learning curve, and if you start sort of putting some effort, you can master it quite easily. Okay, just what do you think this is? Sorry. This is a small polyp, 6 millimeters. Is it hypoplastic polyp that you would leave alone? Low-grade adenoma, you do a polypectomy. You do high-grade dysplasia, you're going to do an EMR, ESD, or say invasive cancer, you're going to operate. Right? 3? Yeah. It's only 6 mm. And I remember when we were taught, we were told that a polyp is more than 10 mm, then the chances that is malignant. See, that is obsolete. We have patients who are 2 millimeters and 3 millimeter polyps with very aggressive histology. So you have to interrogate. And if you look at this, if you just put a little methylene blue or indigo carmine, you can make out that this is got a depressed lesion. Depressed lesion. So it's what we call a Paris 2C. And once you have Paris 2C and you look at these vessels, this definitely is showing submucosal invasive cancer. So you've got no business trying to resect, send it to the surgeon. So these are important decisions that you can take when we use this technology. Now you would argue and say, how does it matter? I'll remove it, send it to the pathologist, and let him figure out. After that, I'll refer to the surgeon. Well, the question is that if it hurts my intellectual sensitivity that, my diagnosis is wrong. A diagnosis that I could have made, I don't want my pathologist to make. But what is more important is in the process of doing this, you may find yourself sitting and handling bleeds and perforations. And that is where you start getting into trouble. Okay? So it's a good idea to be comfortable with this kind of diagnosis and making those steps, hierarchical steps. If you follow, you should do well. Okay, now this is a hyperplastic polyp. This is a serrated polyp. All of you agree that serrated polyps are important or not important? They're important because they give us an alternative pathway to develop colorectal cancers, and early. They come on much earlier. The time taken to become cancer is much shorter. So if you miss out these and say come back after 5 years or don't come back at all, because we don't have a screening program, he or she may develop a cancer a few years down the line and may come back to you, or worse, go to your rival. I say, उसने किया था, हाँ पता है था, miss करता है रोज. Right? So it's a good idea to be comfortable with diagnosing these and knowing what are the characteristics. Finally, we have artificial intelligence, the newest toy. The whole idea is to minimize the miss rate of our lesions and possibly may also shorten the learning curve. You have one of this is the CADE for detection and the KDEX for diagnosis. So once you are using it, it just puts up a box to light up and says, hey, look here again, there's something happening here. Or it may also give you you focus on a lesion, it may tell you that this is a 96% chance that it is neoplastic. So you have these artificial intelligence that's coming up. I'm sure in the next few years we'll see more of these in our country, hopefully developed in our country so that the cost comes down. So to finally conclude, what should a referring clinician expect from his endoscopist in 2021? One is understand the patient's problems and risk factors, and that's what I alluded in the first slide, is go prepared with whatever data you have about the patient and say, okay, this guy is slightly high risk. I need to spend a little more time use available endoscope to its maximum capacity or capability. A lot of you say, oh, I don't have the kind of scopes that Nagi Reddy has got in AIG. Fine. It doesn't matter. Whatever scopes you have, use it well. Spend time. It's been clearly shown that lesion detection is with white light endoscopy. Lesion interrogation is with advanced techniques. So if you don't use your techniques to detect a lesion,